All right, it's a do-over. I'm Lisa Ricciardi. You're the guest. Delighted you're here. Philip, a pleasure to see you. Let us talk about our recent results. We're a public company, filed in October of 21. Overview, we work in the areas like the prior presenters in Alzheimer's disease, dementia with Lewy bodies. We have an oral drug, a small molecule oral drug, by the way, in these conditions, as well as a program in geographic atrophy. So back of the eye condition that we're treating, not with an intravitreal injection. Let me begin by the summer, results from the summer. We were at the AAIC, perhaps some of you were as well. We presented the results of our SHINE trial. This is phase 2 proof of concept in mild to moderate disease. I will acknowledge not that many companies work in moderate disease. We were really pleased about this. The approved drugs have labels in the earlier stage. So 3 arms of drug, a whole set of assessments here. Everything is on our website, so I'm going to move over some of these things quickly. 150 patients, half in the U.S., half not in the U.S., mostly in Czech Republic, the Netherlands, and Spain. Patient population. One thing I am very pleased to tell you, these are all patients that are confirmed with Alzheimer's disease. I love to tell investors, I'm not a CEO who's going to come back and say, we looked at the data and they really didn't have disease. No, you do the trial once, you do it right. It takes longer to do it right, and you all do the same thing. So confirmed disease, pretty much white women, 72 years old, 21 as the MMSE, as you can see the ApoE score. Safety and tolerability profile, this is a clean, mild drug. We were very happy with the results of this. We saw very similar results in our SHIMMER trial. These are patients with Lewy body dementia. So I'll move over this. It's all on our website. Now, looking at the tau burden in clinical trials. In our trial, we had a pre-specified assessment. As the last speaker was talking, Dana was talking about looking at tau, patients who had p-tau 181. We took the patients 130, 150, and arrayed them, levels of tau high to low. And what we found in the low tau patient was a very significant improvement in the results. Here, we like to remind investors, why does anybody look at tau? Well, it's a predictive biomarker of response to therapy. Middle kid calling, sorry, excuse me. Tau very well reflects both amyloid and tau burden, as we know. When you go back and look at the Lilly results, the donanemab trial, what you see in their combined score, patients with lower tau, they use the IADRS, had a 36% slowing, whereas patients in the higher tau group had less slowing. So what we see is if you have a lower level of p-tau, you're going to have a better response to therapy. That's what we thought. And so we conducted this analysis. On the left is the intent to treat population. This is what we presented in Philadelphia, the AAIC conference. So the left is the blue line, 100 and 300 milligram doses. And you see a 39% slowing from here to here over placebo. We thought that was a pretty good result. By the way, it was measured ADAS-Cog 11, 13, cognitive complex, MMSE. We didn't just measure one take on efficacy, there were multiple. And we saw this slowing, which is in fact comparable, if not better, with an oral once-a-day drug with a pretty clean safety profile. The market hated it, so that was a finding. Over here, when we stratified the patients, as I just said, we took the patients that has just literally top to bottom, cut it in half, the lower levels of p-tau, almost no progression in disease. Now, I have great respect for all the folks at Lilly and Eisai. They're wonderful colleagues. Together, we're going to get across the line, but they didn't generate these kind of results. It's a 6-month study. There's more to do, but that was a terrific finding. Now, one thing we find with investors is they go, oh, low tau, that must mean you only work in early patients. And I see people shaking their heads. I'm sure many of you know this in here, which is you can have lower levels of p-tau, whether you have mild disease on the left or moderate disease on the right. You're all familiar with this score, the MMSE. 30 questions, the more you get wrong, the worse you are. These are more advanced patients that had lower levels of p-tau. Look at the result, 91% slowing. On the left, less advanced patients. We sometimes ask ourselves, were folks playing chess at the end of it? Of course not. But these are great, robust results that make us quite confident about moving to the next stage of development. So SHINE, safe, well-tolerated, all the cognitive and functional measures in the right direction. And we are looking at how do we design a phase 2. We had a couple panels this morning about biomarkers and pre-selecting patients, and of course we'll want to do all of those things. Now, Lewy body dementia. We read this trial out 3 weeks ago, maybe. So fantastic. So if you're unfamiliar with it, it's kind of consistent with the reality that even though this disease is as big as Parkinson's disease, no one's heard of it. It's 1.5 million patients. For us, one of the drivers of moving into this disease was right here. These are patients that both have amyloid toxicity and alpha-synuclein toxicity, and we know we impact both. Symptoms listed here. These patients come in with so many problems. As you may know, they take 18 months to get diagnosed. They're either falling first, so the Parkinson's disease doctor sees them, or they have cognitive problems and they get on Aricept or something else. It's 7 doctors, 1.5 years. It's a long time. And of course, what's happening during that 1.5 years? They're not getting better. So one of the important things is to have a drug so that doctors better understand the disease. We get them diagnosed more quickly. Here's AD, 6 million, 1.5 million. You'd see all these numbers. It's an important target. Very similar trial design, 2 doses of drugs. Interestingly, this disease is mostly men, if you're aware of that or not. We always say on AD, you see more women because women tend to outlive their partners. I feel like this is God's way of evening the score, with the diseases. 130 patients all in the US. Now, the biggest challenge here was to design a trial that could actually capture all the symptoms these patients present with. It's really hard to design a study like this. The side effect profile is very much similar to what was in our SHINE trial. So I'm going to move on to some of these results. These patients have behavioral problems looked at on a scale with about 12 different characteristics. Cognitive problems, interestingly, not often the lead thing. Function, activities of daily living, brushing your teeth, right? Movement. You look at this like you would look at a Parkinson's patient. So the first thing we saw when we unblinded the results, and we were so excited, this is the Neuropsych Index. These are the characteristics that are measured. These are our results. Overwhelmingly impactful for patients. Now, Jim Galvin, he's a PI we work with in the US, he always says, Lisa, nobody puts their husband or wife into a nursing home because they don't remember if it's Monday or Tuesday. Like, the cognitive problems are not the driver. However, picture yourself as a little old lady or man taking care of someone who has delusions, hallucinations, aggression. They don't remember you. If you read up on this, you'll get the picture very quickly. This changes from an at-home caregiving situation to an institutional situation. So here you can see the overwhelming response in the direction of drug. Now, this is so interesting. Caregivers. Jim Galvin developed this score. Some of you may be familiar with it. It's a caregiver distress score. So the caregiver comes in with the patient and they get assessed just like the patient does. And what we saw was if your loved one was on drug, you did a hell of a lot better yourself. So this is not that new, but it's impactful and it's profound because it means we might actually change the course of health and illness with our treatment. In brief, cognitive capabilities. In this disease area, there are 3 different characteristics. This is not the same MoCA in Alzheimer's disease, but in brief, you can see in every case, whether you're looking at episodic memory or fluctuations, very important impact on cognition. The fluctuations are really key. I've visited PIs and the nurses go, oh my God, I had to send 2 patients home today. Why? Because they're having an off day. They're on, they're off, the cognition is fluctuating. And these patients will often, they call it show timing, present and you would not know there was anything wrong. Sit right here and talk to us. And in 10 minutes, it's another world. So it's complicated to study these patients. That's in part why we were so pleased by how the study read out. So, positive measures across everything that we studied: behavior, function, cognition, movement, safe and well tolerated. Um, we studied 2 doses in both our trials. I believe that we will move to the 100 milligram dose. And then the big question becomes with the agency, are we going to start to look at a lower dose yet? The 100 and 300 were very similar in terms of efficacy. The 100 had a much better side effect profile. 2 trials are continuing to run. An early Alzheimer's trial, 540 patients. We're running this out of the West Coast with the ACTC organization, and that is recruiting well. That would give us an opportunity to have data in early patients, mild and moderate. It's a big lift for a little company, but we are eager to continue on. And then last, geographic atrophy, back of the eye disease, macular degeneration, geographic atrophy secondary to dry AMD. That trial is actively recruiting right now. We have never announced where we were with enrollment. We don't want to find ourselves in a disclosure situation, but there's great enthusiasm for an oral drug that gets to the back of the eye. You're all familiar with the intravitreal treatments as well. So this is the drug, the program that gets the least amount of attention. People view us as much more neuro-focused. Closing up, here we are, first in class with an A-beta oligomer antagonist. I didn't talk about the mechanism. In essence, this oral drug ensures that the oligomers don't bind to a receptor, the A-beta and alpha-synuclein oligomers. So that's how the drug works. We do not take plaque out of the brain. That also means we're not dealing with ARIA as a side effect either. It's not consistent with our mechanism. Opportunity in DLB, if you don't know this, there have been 8 drugs studied in Lewy body dementia, 8 or 10, and every one of them have failed. No one wishes ill on competitors, but we're thrilled to be out there with such strong data and moving ahead. Oral administration, great IP. This is our drug developed in our labs. Cash position, we announced in the third quarter, $22 million. We've clearly been addressing that, and the K will have an update on that. As a company, we've been given $200 million of funding. 170 from the NIA, the NIH, and then the NIA within that. Michael J. Fox and the Alzheimer's Drug Development Fund, ADDF. This money supports our trial, so that 53 will help pay for the rest of our START trial. And our other trials are done. So Magnify is the one program that comes from our equity capital. So with that, thank you for your attention. Look at that, I'm finishing 5 minutes early.